Good evening, Matthew Welch. It's November 27th, 2021. This is going to be my recording for the Unit 4 cases. I've decided to do case 3 and case number 4. So I'm just going to preface it by reading each case from the case sheet, and then I will kind of prompt off my script to go over what I felt the answer to the question was. So the first one, case number 3, is going to be a 47-year-old male who presented with severe right pain in his great toe. This pain was non-traumatic and it started the prior night. He's been diagnosed with gout and has had urinalysis drawn as well. And the patient also states that he's increased his sugar intake via sugary soda drinks recently. So that's pretty much the gist of the patient presentation. There was a few questions that was asked here. The first one, what is the best explanation for the presentation of gout in this individual? Please explain why the other choices are not consistent with the data or additional information. So the first possibility was an overproduction of purines, and the overproduction of purines can in fact cause gout. However, purine overproduction is fairly uncommon. And usually stems from enzyme disorders or cancer, inflammatory diseases, or cancer treatments. And those, since the patient has a history of that as far as we know, and those root causes usually only account for very small cases of gout, those enzyme-related causes, and typically present much earlier in life. You could do some more testing to rule out overproduction of purines, but given this patient's history on lab results, it doesn't seem like we have an overproduction of urines from an enzyme disorder. The second option was decreased salvage of purines. A decreased salvage of purines in disorders such as Lesch-Nyhan syndrome results in overcirculation of purines, usually from a defect of the HGPT enzyme. This is one of the enzymes that helps take purines and put them back into the nucleotide pool to be used in tissues that can't make their own, such as red blood cells and nervous tissue. These types of issues typically cause a lot more than just gout itself. You would see some other issues such as hemolysis of red blood cells and some nervous system issues because of the lack of those nucleotides available for those specific types of tissues. Again, anytime we're talking about an enzyme-related disorder, these typically present themselves much earlier in life and would kind of go on uncorrected until they're found. So the presentation that this patient has of the recent toe pain isn't really in line with that. A disorder like that of a purine salvage disorder would cause an increase in plasma urate levels. But if we didn't have any renal insufficiency, you would expect to see an increased and correlated excretion of uric acid, which we are not seeing in this patient. The third and final option was decreased urinary excretion of uric acid, and this is probably the most likely cause. First of all, decreased urinary excretion is the most common form or cause of gout, and typically presents itself in older males. It's more common in older males. The reason I selected this one is because we have both an increase in plasma urate and a decrease in urinary uric acid. Anytime we would see an increase in plasma urate, we would expect to see an increase in uric acid in the urine. If there isn't, that means that the plasma urate is likely high because the body is not able to excrete that uric acid via urinary output. In fact, he has a plasma or urinary uric acid excretion level about half of what it should be. So this typically is caused by renal insufficiency. The body is unable to filter out through the urine the additional urate, increasing those high levels and leading to the deposit of the urate crystals in joints like the big toe, causing the gout and the pain that our patient presented with. There should be some additional tests. Obviously, we'd want to know why the patient has decreased renal efficiency, renal panels, as well as looking at the patient's GFR levels to make sure everything is working appropriately. We don't have more systemic issues going on when it comes to how the kidneys are operating. And the patient also stated he switched from diet sodas to drinking regular sodas with fructose or fructose corn syrup in them, and that he drinks approximately 4 to 5 liters of soda a day, which is obviously a very unsafe amount. This amount of fructose intake, when the body has so much of it, is also broken down into purines that can lead to increased levels in the plasma. But again, we'd expect to see increased urinary uric acid levels as well. But anybody who drinks, whether it's diet sodas or regular sodas, at 4 to 5 liters per day is going to have likely some other systemic metabolic issues going on, such as fructose intolerance, insulin intolerance, and of course some renal issues. So overall, it looks like that the reason for this patient increased plasma urate is probably diet related, so he may be able to benefit from changing his dietary habits, especially drinking 4 to 5 liters of diet or regular soda a day, as well as getting screened for some other more complex renal issues like maybe early stage renal disease or things like that. The next case that I wanted to discuss is case number 4. This case is the 58-year-old female who presented with progressively worsening fatigue over the last 6 months, shortness of breath. She's had mild diarrhea as well as some numbness and tingling in her lower extremities. On exam, she has no blood deep blaze stores or blood loss noted. She has a resting heart rate of 110, which is slightly tachycardic, and all her other vital signs are normal. She does have what we commonly call beefy red tongue, as well as a heart murmur, and an decreased sensation in lower extremities, as well as a low hematocrit level with suspected megaloblastic anemia. So the question was, which vitamin deficiency could lead to this type of presentation? And we had 3 options. We had iron, B6, and B12. First off, iron is the most common cause of anemia. However, these patients typically, one, they'll either be asymptomatic, or they'll typically present in kind of later stages with just pallor and weakness. But this is after hemoglobin levels have fallen to an unsafe level. The type of symptoms our patient is having are not typically seen in an iron deficient type of anemia. The things like the beefy red tongue and the nervous system complications are typically not correlated with iron deficient anemia. She also has reported no GI bleeding, and one of the common causes of iron deficiency anemia is going to be some sort of bleeding somewhere, typically from the GI tract, that goes unnoticed for long periods of time. The iron is essential for hemoglobin production, so you're going to see any kind of signs and symptoms you would see with a decreased hemoglobin level, especially like that weakness and pallor. So not really thinking it's an iron deficiency. Our next option was vitamin B6. B6 is a cofactor in quite a few enzymes and metabolic pathways in the body, so B6 deficiency can cause a lot of systemic complications, and is usually found in correlation with some of the B12 and folate deficiencies that we see. A true B6 deficiency is rare, and typically those symptoms that are seen with a true B6 deficiency we're not seeing in our patient. It's going to be things like change in mental status, altered level of consciousness, depression, seizures, skin rashes, and skin lesions, and things like that. None of that is being presented in this patient. More common in the deficiency is as vitamin B6 toxicity from increase or too much B6 intake. But again, the symptoms that we would see from vitamin B6 toxicity are not seen in this patient. So while some of the symptoms kind of overlap with the B12 deficiency, we're not really thinking this is B6, as it's fairly uncommon, and we're not hitting all of the the real signs and symptoms we're seeing in our patient. That leaves us with vitamin B12, which is likely the most likely cause. And vitamin B12 deficiency, some of the signs and symptoms we see are things like fatigue and weakness from the megaloblastic anemia, which is enlarging of those red blood cells. We also see the increased resting heart rate being elevated due to poor or dysfunctional red blood cell production, so the body's trying to compensate for that. And we also see the beefy red tongue, which is caused by those large red blood cells, which is only seen with the vitamin B12 deficiency, so that's kind of one of the telltale signs. This is caused because of both the red blood cells and the epithelial cells in the tongue. Those rapidly proliferating cells are the first to kind of have these DNA replication issues that we see is caused by B12 deficiency. And then, of course, the patient's neurological symptoms, the losing or loss of sensation or in the lower extremities is the most concerning, as this is irreversible, and this is caused by typically what is believed to be an increase of methylmalonic acid or MMA, as well as increased homocysteine levels in the blood, which can lead to that myelin sheath being deteriorated, causing spinal cord degeneration and the secondary symptoms that she's experiencing in her lower extremities. So really pointing towards B12. Some testing that would need to be done, I would say, would be a B6 level, just to make sure we're not dealing with any B6 deficiency, as well as the iron level to make sure we don't have any secondary iron anemia. Bilirubin and liver function test could really help us kind of see how far along this megaloblastic anemia is going. And we should also send some of the red blood cells to pathology so they can confirm that megaloblastic anemia. And of course, a B12 and a folate level should be among the initial testing we get. And then secondary, we also could look at MMA levels or homocysteine levels, which will likely also be elevated in this case. B12 is a cofactor in the folate cycle. It's a cofactor for the enzyme methanone synthase, which aids in producing methyl tetrahydrofolate, which is used by tissues to synthesize purines as well as pyrimidine. So we're going to see both of those pathways affected, but specifically and especially the purine pathway. When it's not present, methanone synthase is not active, which decreases the useful levels of THF we have available for DNA synthesis, and this is what is known as a folate trap. The folate trap and subsequent DNA dysfunction is why we are seeing some of those things we're seeing, like the megaloblastic anemia and the beefy tongue, which are, again, those cells that are more rapidly proliferating, like the red blood cells are constantly being made, as well as the epithelial cells of the tongue. They start to see that deficient DNA before some of the other slower cells, so you start to notice those signs and symptoms first. So that should cover both of the case reviews. Thank you very much for your time, and have a good evening.